A very warm welcome to alumni and friends of WITS to this webinar on South Africa's escalating COVID-19 pandemic. Thank you very much for joining us. I'm Peter Marr, Director of Alumni Relations. I'm pleased to say that around 1,300 WITS alumni from around the world have registered for today's webinar. No matter where you are in the world, I don't need to tell you that these are unprecedented and scary times. At the outset of this pandemic, the South African government instituted one of the world's most stringent lockdowns, and reported COVID infections remained very low during the initial months of the pandemic. In recent times, the situation has changed dramatically and precipitously. According to the World Health Organization, South Africa now has the 6th highest number of confirmed infections and the 3rd fastest rate of infections in the world. Addressing the nation on 12 July, President Ramaphosa declared, "The surge has arrived, the storm is upon us." After my introduction, Professor Gray will deliver a presentation to be followed by answering questions that have been pre-submitted or posted during today's talk, and closing with a vote of thanks by WITSy Dr. Morris Goodman, Chief Medical Officer of Discovery Health and former President of the WITS Convocation. From the numerous questions that have been pre-submitted by guests for today's webinar, it's clear that we need more forums like this one. While it is unlikely there will be time to answer all questions today, my office will endeavour to follow up on any outstanding ones. Our guest speaker, Professor Glenda Gray, is the first female president and CEO of the South African Medical Research Council. She is chair of the Research Committee on COVID-19, bringing together scientific evidence and experience to the Minister of Health and the National Coronavirus Command Council. Glenda studied medicine and pediatrics at WITS, where she remains a research professor in the School of Clinical Medicine. A National Research Foundation A-rated scientist, Glenda is well renowned for her research in HIV vaccines and interventions to prevent mother-to-child transmission of HIV. During her career, Glenda has been showered with awards, too numerous for me to mention them all, but they include being named one of Africa's 50 most powerful women by Forbes this year and listed by Time magazine as one of the world's 100 most influential people in 2017. In 2013, she was awarded South Africa's highest honor, the Order of Mapungubwe. She has been awarded honorary doctorates by Simon Fraser University, Stellenbosch, and Rhodes University. Glenda is known for her compassion, integrity, energy, and determination, her fearless passion to save lives and fighting for the welfare of especially vulnerable communities. As you can imagine, Glenda has been under relentless pressure over the past few months, and so I'm very grateful to her for presenting at today's webinar. Thank you, and over to you, Glenda.
Just hold on 1 second. Are you able to see my presentation, everybody? Peter? I presume everyone can hear me.
Sorry, yes, Glenda, we can see it.
Okay. Good evening, good morning, good afternoon, good evening, and good night, everybody. I'm not sure where you all are, but it's great to be able to talk to other WITSies, both in South Africa and beyond our shores all over the world. And I'm going to just take you through a little journey on the 7-month-old epidemic. And I'm going to, part of it will be historical, and part of it will be biological, and part of it will be medical, as I've tried to cater for all alumni, not just the doctors or the scientists at WITS. And so it's great to be here, and it's great to be part of WITS's celebrations. So I'm going to start off by quoting Francois Venter, who called SARS-CoV-2 a beast of a virus. And it's a beast of a virus because, it's a beast of a virus. I'm just trying to minimize my my screen here because it's my viewfinder is getting in the way, so I can't see my slides. So basically, COVID-19 first emerged in China, and it was first of all identified as a pneumonia of unknown cause. And now it's been found in almost 200 countries with more than 14.3 million people that are dead, and 14.3 million people that are infected, and more than 600,000 people that are dead. In South Africa, we have, as of last night, 351 cases and 4 deaths. And 4,000, just almost 4,000, almost 5,000 deaths. Sorry, I'm just trying to minimize my speaker vert so I can see better, but that's better now. So let's go back in terms of the history. Okay, so on the 31st of December in 2019, WHO receives a report from China about a cluster of pneumonia of unknown cause. Early in January, an investigation is launched, and by the 30th of January in 2020, World Health Organization declares this outbreak a public health emergency of international concerns, as already at that stage, at the end of January, 19 countries in 5 WHO regions with about 7,000 cases already have been identified. By the 11th of March, this is declared a pandemic. And when you go back in the history of COVID-19, you see that the first case was identified on the 1st of December, and then just recently we've heard that another case was identified on the 17th of November. So that's the rapid history of this epidemic. The bottom left corner just shows you the kind of implementation of severe lockdown in Wuhan that attempted to control the epidemic, first with a partial lifting and then with lifting. As you can see, the infection still grumbles on, but appears to be manageable or under control. So at the same time as China was notifying WHO of this unknown pneumonia, a group of people in Canada who follow travel data and who follow an infectious disease vulnerability index started to see this potential international spread of a then unnamed disease, which turned out to be COVID-19. And this article was submitted on the 8th of January to the Journal of Travel Medicine, and this shows us the value of an early warning system. And this early warning system highlighted that there may be 20 cities at risk, and this is based on travel data and, as I've mentioned before, the infectious disease vulnerability index. And I think these are the kind of interventions we're going to have to implement going forward, so that we can make sure that we are able to detect in the future new emerging epidemics or pandemics. So eventually, what transpired was the COVID-19 was found to be a coronavirus, which had a genetic sequence close to the bat strains of coronavirus, has a secondary host, which acquired COVID-19 from bats and was transmitted to humans at the wholesale seafood market at Huanan. And the possible candidate for the secondary host is the pangolin, which is a mammal whose scales are used in traditional medicine. And this little thing is the most illegally trafficked animal in the whole world. So what are human coronaviruses? Okay, there are 4 non-SARS-like human coronaviruses, and they usually cause mild respiratory illnesses. They both occur naturally and with experimental challenge, and they occasionally cause lung disease in immunocompromised persons. You see seasonal activity, winter, early spring. They tend to recur at 2 to 4 year cycles, which suggests that natural protection from infection is not long term. And this, of course, is of concern to us because this type of seasonal persistence is a huge worry for SARS-CoV-2, even though this disease is a little bit different from the other human respiratory coronaviruses we've seen, but obviously highlights the need for interventions like a vaccine, and also demonstrates why this epidemic has persisted despite tremendous efforts of lockdown and implementation of non-pharmaceutical interventions. So if you look at the global distribution of COVID-19, this is just a nice display of how the epidemic has changed over time and how countries and continents have emerged over time. And you can see in the light blue at the bottom is Africa. And so Africa, it's very hard to get a good feel of what's happening in Africa because we are plagued by under-testing. and the only country in Africa that's doing substantial testing is South Africa. But this gives you a feel of how the epidemic has moved over time into Latin America, which is bearing a huge burden of the epidemic, India, and other low middle income country settings. If you look at the 14-day cumulative number of COVID cases per 100,000 population as of today, you can see the countries in dark brown that are heavily burdened. As I've mentioned before, Africa looks like it's not that affected, but it's because there are very little tests that are being done in Africa, and it's hard to follow up in terms of mortality. So I think we're probably underestimating the epidemic in Africa, and we will need to see what happens over time. But you can see that South America is heavily burdened, as is the United States of America. Canada, less likely, and that's probably because of much better testing strategies, testing, rapid turnaround times, identification of cases, and then quarantine, and then follow up of contacts. And that you see also in Australia with a very, very rapid detection of cases and quarantine and isolation of contacts. It's very hard to see what's happening in India at the moment because they also are underplagued by a lack of testing. And so the understanding of the burden of disease of COVID infection really is a function of testing. So the more you test, the more you get a feel of the epidemic, and the less you test, the more it's hard to really understand what the burden is in your country. And so the most important thing is to try and ramp up testing so that you can understand what the positivity case is and have good denominators for understanding the epidemic. But if you look at this slide, now I made this slide for a webinar I did on Thursday, and at that stage, South Africa had just under 300,000 infections, and this is Thursday. And as you can see today, we had 100,000 infections, and as Peter Maas said, we are one of the top burdened countries at a global level. And the reason why our epidemic continues is because we haven't managed to get our reproductive rate under zero. So the only time you can contain an epidemic is if your reproductive rate is under zero, which means, it's under one, which means that one person who has an infection cannot, if it's under one, is likely to infect less than one. You can see the reproductive rate for our country has always hovered between 1.1 and 1.5, and has had similar trajectory throughout the lockdown period. Even though we had a very stringent lockdown period, as Peter Maas mentioned, we had not established community testing at that stage. And it took a while for us to get community testing up and running, which means that we weren't able to identify cases in a timeless fashion and then their contacts and then isolate and quarantine. And so by the time we managed to get our testing up and running, community transmission had already occurred, and we were overwhelmed with testing and took a long turnaround times, and very soon we were unable to identify cases fast enough and their contacts and quarantine them. And then what happens is obviously a runaway train with community transmission that's well established. If you look at the issue around peaking, someone asked the question, when do we know when South Africa will peak? And so we seem to be following the low middle income country setting dynamics, and we have not peaked yet. And we haven't peaked even though we're far above the average where European countries peak. So if you look at Gauteng at the moment, there's about 33.4 daily new infections per 100,000 in Gauteng. And if you look at Chile, it's 14.6 new infections per 100,000 in Chile. If you look at South Africa in total, it's about 19.9 daily new infections per 100,000. And if you look at the figure in Sweden, when they peaked, it was 3.7 new infections per 100,000, and Italy peaked at 9.3 daily new infections per 100,000. and the UK peaked at 8.1 daily new infections per 100,000. So you can see that our trajectory is completely different and is following a trajectory of a low middle income country setting, and possibly similar to what we see in Mexico, Peru, and Brazil. And we have extraordinary high rates per 100,000 and still no sign of the country peaking. In the Western Cape, it looks like we've plateaued, and there may be evidence that the epidemic is starting to get under control in the Western Cape. So SARS-CoV-2 is bad news wrapped in protein, and this is what it looks like. It has a protein-like attachment made up of a spike protein and some proteins. And a lot of the vaccine work that we'll be looking at use the structural proteins, and usually the spike protein to use as an antigen for vaccine design. So this is what the virus looks like, and this is what we have to contend with, trying to make antivirals or vaccines. And so what makes the SARS coronavirus much more severe than any other human coronavirus? What makes it more severe is that this virus invades the deep tissues of the human body, lung, heart, and GI tract. It lands on our nasal epithelium and our lung tissue, and it replicates quite fast in these tissues. And this COVID-19 is 1,000 times better at infecting humans than its closest relative, which is found in bats, because it has evolved from several coronaviruses which were merged together. Scientists at Francis Crick Institute have looked at the molecular structure of the coronavirus spikes and have compared this spike to other coronaviruses found in bats. And they found that this spike is about 97% identical, but has key differences in structure. And this key difference is critical because it makes the virus much more stable and also makes it 1,000 times better at binding to ACE2. And ACE2 is the receptor that's been called the body's entry key, and it's how a person gets infected. And you need ACE2 receptors. We find a lot of ACE2 receptors in the nose, in the lungs, and this is where the virus lands and infects the body. So if you look at this picture, you can see that here you have your SARS-CoV-2 virus. It attaches to the ACE2 receptors. We're using its spike protein, and then obviously you have a viremia. You'll have a pneumonia phase, and then you'll have an inflammatory phase. And the inflammatory phase is you have a huge outpouring of anti-inflammatory markers, a cytokine storm, and an effort to make an immune response to contain the virus. So if you were involved in testing, obviously the most important thing is to try and make a diagnosis of COVID-19, and this is done using RT-PCR, and it's usually most sensitive and most specific around 5 to 7 days after getting the infection, and and then about a week later, your IgM antibodies come up. And then about 14 days later, your IgG antibodies come up. And obviously there's been a lot of hope that the IgG will persist, and that these IgGs that persist will help with long-term immunity. We're starting to see evidence that they are declining both binding and neutralizing antibodies, and these will impact on long-lived immunity and may predispose people to reinfection. And so that's important for us to understand, because it also helps us understand the value of vaccine protection and how long our vaccine response will help to protect people against COVID-19. So what are the transmission symptoms and complications of COVID-19? And I've tried to summarize this just on one slide. And so it's important to understand that transmission occurs through respiratory droplets from contaminated surfaces, and now recently aerosol spread has also been identified as a way of transmission. And obviously aerosol spread is very important because this will take place in congested rooms, possibly in healthcare settings, and also in crowded places where there's poor ventilation, and really emphasizes the need for open windows and ventilation to try and minimize ongoing transmission. But we also know that a lot of transmission will occur in the pre-symptomatic phase, and a lot of people are also asymptomatic. And it's estimated that up to 70% of people who have COVID-19 are actually asymptomatic, and you may not know. And so that is why it's important to wear masks and to implement the non-pharmaceutical interventions so that you can protect the onward propagation of this virus. But for people who get COVID-19, they may experience a fever, a dry cough, shortness of breath, fatigue, pains in the muscles, nausea and vomiting, diarrhea, headache, weakness, rhinorrhea, and loss of smell and taste. There will be abnormalities that you will see, which include lymphopenia and inflammatory markers, as well as abnormal coagulation parameters. If you did an X-ray, you might find evidence of a bilateral lower lobe pneumonia and ground glass opacities and consolidation if you did a CT scan. There are lots of complications, and they include pneumonia, ARDS, acute liver failure, cardiac injury, heart failure, thrombotic phenomenon and microthrombotic phenomenon, neurological manifestations, renal failure, and acute cerebrovascular disease and shock. And obviously, the big complications in hospital are around people who have these cytokine storms and a macrophage activation syndrome. And this slide just summarizes some of the multi-system or multi-organ diseases, but also shows you how over time we become better at managing these COVID infections in hospital. And this slide showing the reduction in mortality by almost 23% comes from data from Discovery that monitored people in South Africa over time. And as people understood how to manage COVID-19, and we've got new interventions, there was a reduction in death. And nursing prone, using oxygen early, using high flow nasal oxygen, the use of steroids and dexamethasone, making sure that your patients are anticoagulated, and looking at other interventions like antivirals like remdesivir and IL-6 inhibitors may also further impact and improve outcomes in the ICU. If we look at the cumulative cases by age in South Africa, we follow the same kind of pattern that we see in the rest of the world, where young children seem to be less affected than older, and that the majority of COVID cases are found in the young ambulant people that are out and about in their neighborhoods. When we look at hospital admissions, we also seem to appear to follow the same distribution of hospitalizations and death by age as most other countries in the world, where most people who are admitted are in the 50 years and older, and we see an equal distribution of men and women, slightly more men. And then you can also see what's important is that very few children are admitted and very few children die, and it's very similar to what we see in the rest of the world. We have a lot of mortality in the over 55-year-olds, and we see a lot of comorbidities that are associated with mortality, and commonly are diabetes, hypertension, obesity is a big risk factor, HIV and TB that is active also is a risk factor, as well as other comorbidities that are seen in the rest of the world. We do seem to have a much younger population that are getting severely ill, and that also could be a marker of obesity and an increase in non-communicable diseases that we find in South Africa, as well as active TB and HIV. If you look at deaths in school-going children, what's very important is to reassure the public that deaths in children have not increased over time, and that our mortality rate in children follow the rest of the world, that children with COVID are less likely to progress. They seem to manage COVID-19 much better, and this may be a combination of them having less ACE2 receptors, a different immune response, as well as maybe more recent exposure to other coronaviruses that may impart some cross protection to them. So we're still looking to see, exactly why children are spared, largely spared from any morbidity and mortality. But that is good news for all children at a global level. It's always very hard to understand how many deaths are occurring from COVID in South Africa. The official reports show that there are around 5,000 deaths, and we have been monitoring mortality, and the MRC has been monitoring mortality for the last 25 or 30 years. And so we have a good indication of how death changes over time, and we monitor this year and year, and we have a forecast for the year. And if the actual death rate deviates from the forecast, we are able to see what the excess rate is. So we've seen an excess death rate of around 11,000 people since the 6th of May. And this is mostly pronounced in the over 60-year-olds. Now, the excess death rates could be a result of three things in South Africa. It could be a result of people dying before they get to hospital. It could be a result of people dying from COVID-19, but doctors are not reporting them properly on the death certificates, or it could be a mixture of both COVID and non-COVID cases, like people coming in and dying because they have TB or HIV. And so we do have to try and differentiate how much of the excess death that we see from what's been reported by the department is actually due to other causes related to health services being reorientated during a time of the epidemic. If you have a look at the Cape Metro, the good news to say is that it seems that our death rate seems to be declining in Cape Metro, and we hope that this will continue, which also correlates to the fact that our epidemic seems to be under control, and the hospitals seem to be able to manage the cases at the moment. If you look at the Johannesburg Metro, you can see that you're in the middle of a surge. And already we're reporting around just over 11,000 excess deaths. 1,120 excess deaths since the 10th of June. And this hopefully won't get worse, but we will continue to monitor this. And it's always a good indicator when the death rates start to go down, is that the epidemic is largely under control. So there you see a surge in the Johannesburg Metro. Moving to trying to find a biomedical intervention to stop this onward propagation of this contagious coronavirus, and trying to understand how can we make a vaccine so quickly, and what are the challenges to making a vaccine to try and stop the onward propagation. We only have non-pharmaceutical interventions to prevent the onward propagation of coronavirus. We only can use masks, wash our hands, and implement social distancing. And so without a vaccine, we pretty much have to implement these until the coronavirus circulates out in the 2 or 3 seasons time. And so normally, if you have a look at a vaccine development pathway, you can see it takes between 10 to 15 years to make a vaccine. And that's because there's a sequential approach to making a vaccine which is risk averse. And we've tried to change this in SARS-CoV-2 to try and do everything kind of at the same time, and running phase 1 trials while trying to make sure your non-human primate challenges models are working, and at the same time planning your phase 3 study. And you can see that it's that there's a hope that we could get a vaccine in 12 to 18 months. And you can see how challenging this is, given that it took us 60 years to find a vaccine for polio, 15 for Ebola, for SARS-CoV-1, we still don't have a vaccine. And for MERS, it took us no vaccine, and it's been 6 years. And so you can see that it's a very ambitious attempt and a race against time to try and find a SARS-CoV-2 vaccine. So how would we approach this? And those most important approaches have been have been 3 ways. One is using messenger RNA coding for a SARS-CoV-2 gene, and this is the vaccine development that's most advanced, and this is the Moderna trial, and we'll talk about that later. The others is using a recombinant SARS-CoV-2 surface protein, and the other common and which we're investigating in South Africa at the moment is using a viral vector that packages a SARS-CoV-2 gene, and then hopefully these stimulate an immune response that makes both neutralizing and binding antibodies against SARS-CoV-2. So if you look at the current vaccines, there are a lot of vaccine candidates, and every time you look, there are a little bit more. And you can see the distribution, a lot of protein-based ones, a lot of both viral vector that are replicating and non-replicating, as well as RNA and DNA and inactivated and attenuated SARS-CoV-2. And the diagram on your left just shows you the various strategies for moving forward for a vaccine. People have asked, why is South Africa not involved as scientists are developing a vaccine? South African scientists are doing preliminary work. We've got a lot of people working in the laboratory, and we do have a non-human primate facility to look at challenge. And we are working both in looking at the structure of SARS-CoV-2 as well as looking at the neutralizing antibodies. But it does take billions of dollars to make a vaccine. So a lot of the companies that are moving forward with the vaccines have got between $500,000 to $1 billion to do their development. So you can see that kind of money needs you need a big response, and you need a lot of resources to move forward. And South Africa does need to increase its R&D potential and realign and make sure that a lot of money goes to basic science to develop platforms for novel vaccines that may move forward in the future. It's very important to also note that a lot of these vaccine platforms that we're using at the moment actually were developed for HIV, for Zika, and for Ebola. And so having a good vaccine platform means that you can take the antigen from a new pathogen like SARS and stick it into your platform and use the same black backbone as you've used for HIV, Ebola, and Zika. And that's exactly what's been happening with the vaccine design currently. These are the timelines. So South Africa is involved in two platforms. Currently, as you've heard, the WITS run RMPR unit under Shibri Madi has initiated the first COVID-19 vaccine trial in Africa, and this is in collaboration with the University of Oxford and AstraZeneca, and it looks at a chimp-ad viral vector. We are going to be starting an AD26 SARS-CoV-2 program with Johnson & Johnson, and this is scheduled to start, if everything goes well, in mid-September. There's also negotiations with Novavax to look at the use of their protein-based vaccine in designs. These are the timelines, and you can see that we're all very much on the left, and that the furthest vaccine that's along is actually the Novavax, the Moderna, and the viral vector chimp-ad from Oxford is the most advanced program to date. So we will know, hopefully we'll know, we hope that there will be 400 million doses at the end of 2020 for the chimp-ad study, and 100 million doses for Novavax, and 1 billion doses for the Moderna mRNA study. So this just shows you, this was published just recently. This is the mRNA study by Moderna, and this just shows you the dose response and some of the immunogenicity. You can see good neutralization responses after 2 doses, especially after 2 doses. And you can see on your right the antibody responses, particularly profound after second vaccination. The dose that's been chosen to advance into efficacy is the 100 micrograms, and these studies should be starting in the next couple of weeks in the USA. A study that was done in China deserves some mention. This was an AD5 vaccine program, and it also used the spike antibody, the spike antigen. This shows you the CD4 and CD8 T cell responses, as well as the antibody responses. This does look promising, and it's gone into efficacy in China amongst the military. In South Africa, we are looking at whether we should move ahead with an adeno type 5 vector, as we had earlier problems with an HIV vaccine that was an Ad5 based vaccine, but we'll be having regulatory, scientific and ethical consultations to see whether there's merit in advancing a second generation Ad5 COVID vaccine in South Africa that seems to be quite promising. The vaccine trial that is happening in South Africa is the chimp ad run by Shabir Mahdi. This is funded by the MRC and the Gates Foundation, and it's a phase 1/2 adaptive design that's looking at the safety and immunogenicity and preliminary efficacy of the non-replicating chimp ad vaccine in South Africa. And this study has already started. It's taking place both in Soweto and at the and in Esalen Street. And hopefully the vaccine sites will be expanded to Western Cape very soon so that we can expand the enrollment of the study. Already we have very illuminary people that have volunteered for the study, including Martin Villa, the current Dean of the Faculty of Health Sciences, and Professor Francois Fenter. Yeah, you can see them getting their first jab last week. And there you can see on your left is Shabir Mahdi, who's the investigator for the study, and showing you that WITS is always ahead, and wonderful that we were able to initiate these studies, and that Shabir is providing great leadership in taking COVID vaccines forward. I wanted to touch just briefly on the issue around de-isolation and quarantine, because there has been some confusion in the public about how long people should be de-isolated and quarantined for. So for the COVID positive healthcare worker, so when you are going to be de-isolated, if you've had a mild case, you usually are de-isolated 10 days after your symptom onset. If you've had severe disease, we recommend that you de-isolate 10 days after you're clinically stable and after you've come off oxygen. We don't recommend repeat PCR testing, and that you assess your medical fitness for return to work and able to fulfill your duties. And we estimate that this will be around 10 days after either you're clinically stable or your symptoms have disappeared. These guidelines are available now on NICD, and the Minister of Health sent out a public release this weekend to show that the changing of these guidelines. In terms of quarantine, how long should a healthcare worker be quarantined for? If there has been high risk exposure, which is less than a meter with no or inadequate PPE, or less than a meter, and there are no symptoms, we are suggesting that you do a PCR at 5 days. And if you're negative, you de-isolate, you return to work with full PPE, and you monitor symptoms and you avoid immunocompromised patients. For the general public, we have other recommendations. So if you're a member of the public and you've had COVID, we are suggesting that you can de-isolate 10 days after symptom onset. And if you've had severe disease, also 10 days after clinical stability has been achieved, and there's no need to repeat PCR testing, as the PCR won't differentiate viable virus from presence of virus. And obviously, you should get a medical fitness to return to work. For quarantine, we are suggesting no change, and that people who have high risk exposure quarantine for 14 days, then de-isolate, and that no repeat testing is required. So these guidelines are available, and you can check them on the NICD website. It's very important for all of us to know what we have to do. We don't have a vaccine, and we don't have readily available antivirals in South Africa. And so we all have to do our part. And this is a lovely video that just shows you how important it is to wear a mask, that you should cover smart, do your part, and slow the spread, and make sure you use masks, that you avoid congestion, you implement physical and social distancing, and that you maintain good ventilation and good hand hygiene and good cough etiquette to try and prevent the onward propagation of virus. Every person in South Africa has a responsibility to implement non-pharmaceutical interventions to help contain the epidemic. So I just want to acknowledge a few people before I end, particularly Francois Fenter, Lucille Bloomberg, Debbie Bradshaw, Shabir Mahdi, Larry Corey, and Emil Stepp. And also I want to acknowledge at a global level and at a local level, all the doctors, nurses, and allied healthcare professionals that are out there working to keep us safe and well in hospital. So thank you very much, particularly to the healthcare workers. Okay.
Thanks, Glenda. So I know quite a lot of guests submitted questions beforehand to us, and I see quite a few being posted here now. Are you able to go through some of those?
Yeah. So the first question is, please discuss the peak for the different provinces and the implications thereof. And so the peaks have happened at different in different provinces based on different dynamics. And it's estimated that the virus was well established in the Western Cape due to the tourist season long before most of the country. So there was that reason why probably Western Cape was the first province to increase, but also Western Cape normally starts its viral infectious diseases in winter much earlier, and so it's probably a combination of the geographical nature of the Western Cape, as well as the seasonal variation, as well as the fact that there was a lot of tourist activities, people from Holland, Britain, and Europe coming to South Africa. I think one of the first viruses that have been looked at in the Western Cape have actually come from a Dutch origin. And so that's probably the reason why we peaked first. Eastern Cape would be second to peak because of the movement between the Western Cape and the Eastern Cape. And so there's a lot of movement. And so it's natural that the Eastern Cape would peak straight after the Western Cape. Gauteng would be the next one, just geographically in terms of movement of people. And you've seen that happen. The Free State has remained relatively low volume, but that seems to be picking up, as well as the Northwest. And Mpumalanga and Limpopo seem to be lagging, and we believe that KwaZulu-Natal will start peaking between September and October, given that they have a real mild winter. And so that's why the different peaks are a combination of how soon community transmission sets in, and also the nature of winter in our country. I'm sorry if the audio is very slow. Hopefully you can hear me. Hopefully I can speak up a bit. And the next question is, what will happen if we simply kill off the body's ACE2 receptors? What we have to look at is we have to look at drugs that block the virus from binding onto the ACE2 receptors. And so that should be one of the targets of the drug that looks at the part of the virus that binds onto the ACE2 receptors and blocks that and protects the body from it being attached to the ACE2 receptors. So that's a nice question for us, for the pharmacologist to look at. There's a question about how much time does it take from the virus touching the mucosa for it to start replicating, and can that be intercepted? So I guess that could be intercepted if we had a vaccine. So if there was a vaccine and you got exposed, and the moment there was an attachment, there would be an immune response that would neutralize the virus or bind the virus, or have some immune response that would inactivate the virus as it got onto the nasal surface. And so that would be important. So the best thing for that would be a vaccine. There are people that are working on monoclonal antibodies, and if you were exposed to the virus, one could think about using pre-exposure or peri-exposure use of a monoclonal antibody that would mop up the virus and protect it from spreading further. So there is work being done on monoclonal antibodies, and trials will be started. Some of the trials already started, and further trials will happen mostly in the US, but there are some sites in South Africa that are touted to do this. Do you think the government has managed the pandemic rationally with regard to things like school, taxis, alcohol, and tobacco. Okay, so I'll address the issue. I'll address them all. I'll start with tobacco. So I do think that the banning, the prohibition of tobacco was not well thought of, and that probably we should have allowed for the sale of tobacco because people can get it on the black market. It's easily available, and contraband or illicit cigarettes are fully available in the country. So no one has stopped smoking. We also know that nicotine addiction is one of the worst addictions in the world, and so you will do anything to get your tobacco. And if it's easily available on the black market, not making it available legally means that we lose revenue. In terms of alcohol, there was a good rationale to ban alcohol, to keep hospital beds open. We do know that alcohol increases trauma-related accidents, particularly at night. And so by banning alcohol and by having a curfew, you try and keep your bed occupancy down and try and keep doctors realigned to manage COVID cases instead of managing alcohol-related trauma. We also did see a lot of a resurgence of gender-based violence with alcohol use, and that's also another way to try and prevent further morbidity and mortality that affects the health system. Could we have done something better? Was an alcohol ban the best thing that we do? I think that South Africa needed something very drastic for a short period of time. So I think one could have chosen in a severe lockdown, or you could have tried. We needed hospital beds, and so the most impactful thing to do was to try and prohibit alcohol in that period or decrease its consumption. One could argue that you could have curtailed sales, maybe sold less to people using an ID document, maybe only sold on certain days of the week, and maybe only sold for certain hours. And so maybe those are the kind of things that could have been implemented. But I do believe that we had to manage alcohol to keep the beds open. And so either a temporary ban on alcohol or a reduction in its use would have helped us protect the beds that we needed. In terms of taxis, we do know that the virus is spread in congested areas, and so it's very important to make sure that taxis' windows are open. When I drive in Cape Town, I see the taxis' windows are still closed. I know it's cold, and so people should be wearing blankets and jerseys, and also maybe making sure that not only do you have a mask on and that you're washing your hands or sanitizing at all time, but you keep a visor or a face shield as well on it. In terms of occupancy, obviously the less congested a taxi is, the better, and the more congested a taxi is, the worse it is. And so so we know what the risks are associated with congestion, and we need to try and avoid it. In terms of things like school, that is a difficult thing. School is a highly emotive issue. Parents are very worried that their children are going to get sick and die from COVID-19 at school. Teachers are worried about getting infected by pupils and are scared about opening school. And everybody it's always a very emotive issue when you talk about schools. But we do know how to protect our teachers. We did need to know that people who are over a certain age group with comorbidities need to not be teaching in the front line, and they should be supporting teachers who are teaching in the front line. We do know that the younger teachers are going to be better off than the older teachers, and we also know that if teachers maintain non-pharmaceutical interventions, make sure their classrooms are open, good ventilation, and that when they go to the tea room, they also maintain distance and wear face masks, you can minimize the transmission. And we do have other people working. We have shop tellers who you see a huge amount of public people. We do have policemen that are out there managing crowds and congestion. And we do have nurses and doctors who also work in areas who are using non-pharmaceutical interventions and PPE as prescribed to minimize transmission. We also know that other areas of people who interface with the public, like Department of Home Affairs, also face the public and have lots of congestion. And they need to be protected by making sure that there are shields in front of them, they're using masks, and that they're minimizing overcrowding in the areas, as well as making sure that there's good ventilation. And so I think what we have to try and do is try and understand the fears of parents and the fears of school teachers, and try and support them in a way to make sure that they can continue to keep the schools open and that they feel protected. And I think it's all about communication around the schools. In terms of looking at funding, yes, we don't have enough money in South Africa for funding. Even though the MRC and the NRF get money, they never get the kind of money that you get at the NIH. And so our baseline budget at the MRC is around 600 million Rand, and we've been able to free up about 100 million Rand. The Department of Science and Innovation have been able to also free up a lot of money, and we've been able to use this money to invest in everything from basic science to surveillance. And if we are interested in innovation and we're committed to vaccine development, then we have to make sure that we get much more money for innovation and to help basic science flourish in South Africa. So there will never ever, we can never ever flourish as a country with basic science if we don't fund to the kind of amounts that you see from the NIH or the Gates Foundation. As I mentioned, AstraZeneca is getting around $500,000 to get these vaccine programs going, and so this kind of money South Africa doesn't have, but that doesn't mean that we should not be lobbying to get more money for science and innovation, because it's very important. There's a question about the correlates of protection. So we don't know. We're hoping that binding antibodies and neutralizing antibodies are the hallmark for protection. So we do think that if they're good binding antibodies and we get good neutralization responses, these will be hallmarkers for protection. In non-human primate challenge studies, neutralization and binding antibodies have been markers for protection. And so we will only be able to see whether this plays out when we do the efficacy studies, and we can correlate back to what was the defining moment, what were the neutralization levels you needed, because if you know that you're able to bridge to other vectors, and you might not have to do such bigger trials in the future. There's a question about is there a risk to contract the virus again if you healed of it? As we're seeing waning antibodies, we are worrying about reinfection, but we need to follow this up. So as the antibodies wane, we need to make sure that we can follow up people to see whether reinfection is possible. There may be memory T cells that protect you, and we need to see around 6 to 8 months post-infection whether reinfection is possible. So we are following that. We are worried about the waning antibodies and whether this has an impact on long-term immunity. How can other Wits academics enroll? If you're under 65 and you are living in Johannesburg at the moment, you're able to enroll, and very soon you'll be able to enroll in the Western Cape. When we start the 826 J&J program, we'll have about 30 sites in South Africa, all over South Africa. So we'll have sites in KZN, we'll have sites in Klerksdorp, Rustenburg, Gauteng, and as well as in Free State, Eastern Cape, and Western Cape. So we hope to have about many more trial sites for that trial. With Novavax, we're also hoping to have much more trial sites. So you just have to keep involved and keep listening about where the trial sites are and what trials are happening. Okay, in terms of capacity from BioVac, so we are working with some vaccine developers to transfer technology to BioVac. BioVac is a wonderful entity that has the potential to do fill and finish, as well as eventually antigen transfer. So I think that we are hopeful that that BioVac will be part of the tech transfer, particularly for some of the vaccine programs. Question is, are we using cortisone-based nebulizers early on in diagnosis? I think this has been variable. I've seen variable practice on this. I think you have to make sure that there's 3 phases to the infection. There's the viral phase, there's a pneumonia phase, and there's the inflammatory phase. And I think the use of steroids is good in the pneumonia and inflammatory phase, but it may not be so good in the early viremic phase. So I think the timing is essential. There's a question about, why does this virus have a high vascular impact alongside the respiratory impact? It's a multi-organ disease that causes coagulation issues, and I think it's related to the cytokine storm that we see evolving, and it's probably the movement from the mnemonic phase to the cytokine storm phase, where you start to get these coagulopathies and these microemboli. But this is a devastating disease as well, as in it, also the role of the ACE2 receptors at the body level, and also important to use anticoagulation to minimize these effects. Okay. Will the J&J deal and other companies, what access? So at a global level, we're looking at global strategies to make sure vaccines are available in low middle income countries. And so we do feel as South Africans, the more vaccine trials we do, the quicker we'll be able to register these vaccines in our country, and the quicker we'll be able to have access. And so being able to do these trials definitely helps us in terms of rank order in getting access to vaccines. We're going to need billions of vaccines, and we're going to need billions of doses of vaccines, and we're going to have to make sure that we're part of the global conversation to ensure that we get vaccines in South Africa and in Africa. The effects of COVID-19 on children under 12 and infants, mostly it's a mild disease. I should have put up a slide with that. There are some inflammatory responses in a rare group of kids that lead to what we call a Kawasaki syndrome, but that does appear to be rare, but does mean it needs to be monitored. But mostly kids are largely asymptomatic and have mild diseases. They may have a cough, sore throat, and fever, and mild flu-like symptoms, and not as bad or severe as older people. What is the effect of COVID-19 infection on the fetus in the first trimester? So we've been following up at a global level pregnancies in women who've been exposed to COVID-19, and it seems that there may be a risk of preterm labor and prematurity, but at this moment in time we haven't found any anomalies or any congenital abnormalities besides preterm labor, and we do recommend that women breastfeed their babies. I think I've seen one report that needs to be verified of a possible transmission, but that still is accumulating. But there have been lots of women who have been pregnant at a global level, and we need to follow up these infants and try and articulate further the transmission risks and what if anything is the impact on the fetus. In terms of asymptomatic transmission, I think, basically we do know that a lot of transmission and a lot of people will be asymptomatic. So it's very hard to know who hasn't got COVID and who is just asymptomatic. And that's why it's important to wear masks. So if you are expelling virus, it gets caught in your mask and it doesn't transmit further. And that's just the importance for washing hands and making sure there's ventilation. And so that if you are asymptomatic, you basically don't increase the onward propagation of the virus. To mask or not to mask, I do believe that there is evidence that masking will protect. If you are asymptomatic, or if you have viral shedding, the virus will be on the inside of your mask. It will minimize being transmitted to other people, and that you will protect other people by wearing masks. Obviously, it's very important how you manage your mask, not to touch the outside of it, not to scratch your eyes, and to try and make sure if you do want to scratch your nose, is to use the inside, and not to touch the mask and the material outside the mask. Those are all very important, how you manage your mask. So there's a question about prediction. How long will it take for us to see some decrease in the number of cases recorded each day? That's very hard to show. You know, as I showed before, South Africa hasn't peaked yet, and we'll only know when we've reached our peak, when we start to see the infection rates stabilizing and the death rates going down. The only way we can manage our peak is to make sure that we implement non-pharmaceutical interventions, and that we as citizens, you know, buy into how we support the country in not being part of the transmission events. And so it's very important using NPIs for us. If masks are worn, why is socially distancing still important? Well, because there may be aerosol transmission. There may be your mask may not be protecting all the droplets, and the way you wear your mask may, particularly if you wear your mask below your nose, you may be able to transmit the virus still. So masks are important because they're the first line of defense. Social distancing is the second line of defense, and the third line of defense is to make sure you wash your hands, particularly when you've been in crowds or when you've been touching surfaces. And the fourth line of defense is to keep your windows open and avoid congestion. I think I like soap. I like lots and lots of soap. It's a fatty virus, and using soap is important, or alcohol-based alcohol-based hand washes. And then there's a question about stats. In reporting the stats, is differentiation made with the COVID is a comorbidity? There is still issues around how we do our death certificates, and there's some confusion about whether it's a possible, probable, or causal, or commensal with the thing that caused death. And so we are trying to train medical doctors to fill in the death certificates properly. On our website at the MRC, we do have some guidelines, and the WHO has some guidelines. I think, Morris, I'm already 2 minutes over, so I think I'm going to hand over to you. And we can, I think, Peter, you can send me the rest of these questions afterwards.
Thank you.
So I hope I've done enough, and you'll send me the questions and I can send them by email.
Thank you, Glenda. You've been amazing. I'm really grateful for all the questions everyone's posing. What I can say is that WITS has, I've got access to a lot of WITS experts in this field. And so we'll be arranging future webinars where we can also address some of these questions. So I think this is just part of an ongoing conversation, but I'm very grateful for all the questions that were posed. We'll see which ones we can get back to you on. Thank you very much, Glenda, and over to you, Morris.
Well, just from me, again, thank you very much, Glenda, for an extremely frank and informative presentation. As you pointed out, we certainly are at a critical period in this country with the COVID surge, which is upon us. And the next month or so will no doubt be an extremely challenging one for South Africa. But on behalf of the convocation of WITS, the whole WITS family, and indeed all the people of this country, I'd like to say how fortunate and how proud we are to have people of your intellect, commitment, and passion to guide and lead us through this challenge. And this certainly gives us hope. You know, as a country and as a people who have overcome many challenges, we know that we will make it through this. And so just in closing, I'd also like to thank all of you, WITSies from around the world, for joining us on this webinar. And would just like to remind you of another webinar coming up on July 29th at 7 p.m. South African Standard Time, in which our current Vice Chancellor, Professor Adam Habib, will be introducing our new and very exciting Vice Chancellor designate, Prof. Zeblon Vilakazi. So please do join us for that. And thank you. Just keep safe and keep strong. Thank you, everybody, and good night.
Thank you, Morris. Good night, everyone.